You really wouldn't think the timing of like a tiny localized injection in the pelvic mucosa would require this incredibly strict hematological analysis.
Right, you'd think it's just a simple aesthetic or localized procedure.
Exactly. But when you're treating the aftermath of pelvic chemotherapy, literally a single day's difference in a white blood cell count separates this amazing regenerative breakthrough from, well, a life-threatening systemic infection.
Yeah, it's a massive physiological balancing act.
So welcome to today's deep dive. We are jumping into a highly specialized and honestly crucial mission for you today. We're analyzing clinical literature, medical FAQs, case studies, all to uncover the exact safety timeline for administering intimate polynucleotide injections.
Specifically in patients who have recently finished pelvic chemotherapy.
Right, because we're exploring this really intense intersection of cutting-edge regenerative medicine and oncology. And this knowledge is just so empowering for cancer survivors who are trying to reclaim their quality of life, post-treatment.
It really is. The clinical intersection here is just incredibly demanding because it forces us to reconcile the aggressive systemic suppression from the oncology protocols with these localized regenerative ambitions we have in functional medicine.
Yeah, because you're dealing with tissue that has been fundamentally altered.
Exactly. Altered at a cellular level and inside a patient whose systemic immune defenses have just been temporarily dismantled.
Which brings us to the why. Like, before we map out exactly when it is safe to inject, we really need to establish why pelvic cancer survivors are seeking out this specific treatment in the first place.
Right. We have to look at the biological problem they are facing.
And it is severe. Looking at the literature on treatments for, say, anal squamous cell carcinoma or colorectal cancers, the chemoradiotherapy protocols trigger what's called severe iatrogenic menopause.
Which is medically induced menopause. It's not like a gradual natural transition at all.
No, it's an abrupt, total withdrawal of estrogen. And that precipitates extreme genitourinary syndrome of menopause, or GSM. So you're looking at aggressive tissue atrophy, profound dryness, and, severe dyspareunia, which is incredibly painful intercourse.
And that sudden drop in estrogen just completely disrupts the homeostasis of the vaginal and vulvar mucosa. The extracellular matrix, which is like the scaffolding, it begins to break down rapidly.
A collagen network basically just degrades. Right?
Yeah, it degrades, and the tissue becomes ischemic, meaning it lacks blood flow. So without adequate microvascular circulation, the mucosa just loses its elasticity. It loses its ability to maintain hydration, which leads to that friability and pain.
Which makes standard interventions highly problematic because the traditional approach to those symptoms would be to use localized topical hormone therapy, like estrogen creams.
Right, which works great for a standard menopause patient.
But for many of these oncology patients, especially if they have hormone receptor-positive histories or are on specific adjuvant therapies, introducing even topical estrogen is an absolute contraindication.
Yeah, you run the risk of stimulating microscopic residual disease. They just can't do it.
So they need a non-hormonal intervention, something that can actually rebuild the tissue architecture rather than just temporarily masking the friction.
And that structural rebuilding is exactly the mechanism we see with polynucleotides.
Or PNs, as we'll call them.
Yeah.
So for those who don't know, what exactly are polynucleotides?
So they are highly purified sterile DNA fractions, and they are typically derived from fish gonads, specifically salmon or trout.
Which sounds wild, but the science is amazing.
It really is, because it's their behavior once they're injected into the submucosa that makes them so clinically relevant for these cancer survivors.
Right, because they aren't just acting as a passive dermal filler like standard lip injections or whatever.
No, not at all. As they break down in the tissue, they release specific nitrogen precursors, nucleosides, and nucleotides.
And from my reading, those precursors are acting as direct signaling molecules. They essentially bind to receptors on the local fibroblasts and kind of wake them up, forcing them out of that senescent state that the chemoradiotherapy put them in.
Exactly. The signaling cascade is the whole point. By activating those fibroblasts, the PNs stimulate the body to synthesize type I and type 3 collagen and elastin.
So to use an analogy, if you think about traditional lubricants or basic moisturizers, they're basically acting like painting yellow grass green.
That's a great way to put it, yeah.
Right. But polynucleotides, they're like refertilizing the soil and repairing the root system so the grass actually grows back healthy on its own. You are triggering the body to permanently restructure the microenvironment.
And the really crucial element for these specific oncology patients is how the polynucleotides address that ischemia I mentioned earlier, the lack of blood flow.
Oh, right, the VEGF stimulation.
Precisely. Polynucleotides stimulate the release of VEGF, which is vascular endothelial growth factor. In a post-radiation, post-chemo environment, the capillary networks are basically obliterated.
So by upregulating VEGF, you're prompting angiogenesis, the formation of new microvascular networks.
You're restoring active blood flow to tissue that has been completely starved of oxygen and nutrients.
Which is just a massive breakthrough specifically for these oncology patients because, again, they get a non-hormonal regenerative lifeline. But this immense regenerative potential introduces a pretty huge physiological paradox.
Yeah, it brings us to the core constraint of this entire deep dive.
Right. Because if these DNA fractions are so incredibly effective at signaling repair and blocking tissue degradation, I mean, why don't we use them during the chemotherapy?
To prevent the tissue damage from happening in the first place.
Yeah. I found myself questioning this exact point while looking through the sources. If this is just natural DNA that helps heal tissue, wouldn't we want it working overtime while the chemo is actively breaking the body down?
It completely seems counterintuitive to wait until the tissue is ruined before intervening. I agree.
So why withhold it?
Well, it seems logical until you look at the systemic cost of the oncological treatment. The sources we have are absolutely unequivocal on this boundary. Active cancer, active chemotherapy, and active radiotherapy are universally listed as absolute contraindications for PN injections.
Absolute contraindication, so a hard medical boundary.
Yes, you cannot inject these molecules during the active treatment phase. And it's not because the polynucleotides themselves are harmful, it's because the delivery mechanism, the needle itself, becomes a lethal liability.
Oh, wow. Okay, so this comes down to chemotherapy-induced neutropenia.
Exactly. The chemotherapy isn't just targeting the localized tumor in the pelvis, it is aggressively suppressing the entire bone marrow.
So the patient's circulating white blood cells are just decimated.
Specifically their neutrophils, which are the primary mediators of the innate immune system. They are the first line of defense against bacterial and fungal pathogens.
And looking at the oncological care guidelines in our sources, they talk about this nadir effect.
Yes, the nadir is critical. Patients typically hit their nadir, which is the absolute lowest point of their blood counts, roughly 7 to 14 days after starting a therapy cycle.
So during this 7 to 14-day window, their systemic defense mechanisms are virtually non-existent.
They have zero defenses. Now, apply that systemic vulnerability to the pelvic mucosa we are discussing. The vaginal and vulvar mucosa harbors a very complex, diverse microbiome.
It's constantly managing a normal bacterial load.
Right. In a healthy state, the intact mucosal barrier and a functioning immune system keep all those opportunistic pathogens in check without you even noticing.
But, and here's the scary part, if you introduce a needle into that mucosa during the nadir, you are deliberately breaching the only physical barrier standing between a heavy bacterial load and the systemic bloodstream.
You're creating a direct doorway for those pathogens. In a neutropenic patient, the body just doesn't have the white blood cells to mount a localized inflammatory response to contain the bacteria that the needle just pushed in.
So what would normally just be a tiny, transient little prick rapidly escalates.
It spirals out of control. The clinical data warns of severe localized infections, rapidly spreading cellulitis, and just atypical inflammatory reactions that you can't easily manage.
Because without neutrophils to fight off normal surface bacteria, that localized breach quickly progresses to septicemia, which is systemic blood poisoning.
And that carries a very high mortality rate, which obviously supersedes any regenerative goals you might have for the tissue.
Right. So the physical act of injecting is the variable that makes this absolutely contraindicated during active chemo. Which brings us to the next big question. The chemotherapy ends. Does a timer start?
You mean, how do doctors and patients know the exact day it becomes safe to begin the injections?
Yeah, like as a patient or practitioner, you aren't just circling a date on a calendar 30 days out, right? Are you literally looking at a blood test to get the green light?
You absolutely are looking at a blood test. A chronological timeline on a calendar is clinically useless here because bone marrow recovery is highly variable from person to person.
Because it depends on the specific chemo drugs, their age, their baseline health, all of that.
Exactly. The safety timeline is dictated entirely by hematologic recovery. It's physiological. The safety window only opens when the blood work proves the immune system is functional again.
So what are the specific medical thresholds required before injectables become safe? The sources mention the ANC.
Yes, the absolute neutrophil count, or ANC. That is the exact biological marker for that first line of defense.
And what number are we looking for?
The guidelines dictate that the ANC must rise from the nadir and stabilize above 1,000 cells per cubic millimeter. Anything below 1,000 means the patient remains in a state of neutropenia, and they carry a huge risk of septicemia.
So ANC above 1,000 is the first threshold. But that's not the only metric, is it?
No, because bone marrow suppression also impacts your platelets. So thrombocytopenia low platelets is a parallel risk.
Because platelets dictate clotting. And the sources note that hemorrhage is a severe complication if platelets are below 50,000 per cubic millimeter.
Right. If you inject a polynucleotide into the highly vascularized submucosa and the patient has platelets below 50,000, that tiny needle track simply won't clot.
You risk a massive submucosal hematoma.
And a hematoma in a patient who is still recovering their immune system, that becomes a perfect incubator, an ideal breeding ground for bacteria.
Which puts you right back into that severe infection risk. So the safety timeline for administering PNs post-chemo is defined by the moment a patient's blood work confirms their ANC is greater than 1,000 and their platelets are greater than 50,000.
That dual confirmation officially moves them out of the immunosuppressed danger zone.
Okay, so once that strict hematological safety threshold is crossed and the patient gets the green light, what does this actually look like in the real world?
Well, the aesthetic and medical guidelines confirm that dermal and mucosal injectables safely transition from contraindicated to safe, and the results are incredible.
I want to highlight this specific, really compelling clinical case study from the sources. It was published in the International Journal of Women's Health.
Ah, yes, the 42-year-old woman. That study provides a rigorous blueprint of this exact post-treatment protocol.
Yeah, so she was 42, suffering from severe iatrogenic sexual dysfunction and intense neuropathic pain after going through chemoradiotherapy for anal squamous cell carcinoma.
And at 42, the sudden onset of that severe degradation is just catastrophic to her quality of life. The cancer was cleared, but the ischemia and tissue obliteration essentially destroyed her intimate function.
But once she was safely in her post-treatment window, meaning she hit those blood work metrics, she underwent a very specific treatment protocol.
She did. Over a roughly 4-month period, she underwent 6 sessions of intradermal, vulvar, and submucosal vaginal injections.
But they didn't just use polynucleotides, did they?
No, the practitioners utilized a combination therapy. Shia received hyaluronic acid, or HA, delivered alongside the polynucleotides. Specifically, a variant called PNHPT, which stands for High Purification Technology.
And injecting both together makes so much sense mechanically. Because the HA provides this immediate mechanical relief. It addresses the depleted volume quickly and brings immediate hydration.
Right, because hyaluronic acid binds and retains water molecules instantly. So the patient gets rapid symptomatic relief from that severe dryness and friction.
But the HA degrades relatively fast. That's where the polynucleotides come in for the long haul, right?
Exactly. While the HA manages the acute symptoms, the PNHPT is in there for long-term dermal and submucosal extracellular matrix regeneration.
It's continuously signaling those fibroblasts over those 4 months to make real collagen and rebuild the microvascular network.
So by the time the injected HA naturally degrades, her own tissue has biologically rebuilt its structural integrity to sustain hydration natively.
And what of this case study is just phenomenal. The outcome was highly successful.
It provided relief from her severe neuropathic pain and successfully restored a satisfying sexual life. It fundamentally reversed the iatrogenic damage.
Which proves that respecting that safety timeline, waiting for the post-chemo window, it yields truly life-changing results without risking infection. But, and this is a crucial caveat we have to remind you about, there is one absolute contraindication that never goes away, regardless of your blood work.
Yes, the allergy risk. Because these PNs are derived from fish DNA, a severe fish or seafood allergy remains a permanent absolute contraindication.
Right. Even though the PNHPT, the high purification technology, strips away almost all the immunogenic proteins, if you have a history of anaphylaxis to fish, it's just not safe.
It's a hard biological boundary. Practitioners must screen for it relentlessly, even if you have perfect oncological clearance.
So bringing this all together for you, the timeline for safe polynucleotide administration after pelvic chemotherapy is strictly dictated by the immune system's recovery from neutropenia.
It is an uncompromising data-driven window.
You have to wait for the absolute neutrophil count to surpass 1,000 per cubic millimeter and for platelets to stabilize above 50,000.
And by hitting those marks, patients transition safely from a state of absolute contraindication to being ideal candidates for this life-changing regenerative therapy.
As we wrap up, there's a really provocative thought I want to leave you with, something to mull over. We've established that injectable polynucleotides require waiting for immune recovery because the needle breaches the skin.
Right. The needle is the infection conduit.
Well, the sources also mention that topical polynucleotide creams, specifically a product called Leany Radio, are actively used during radiation therapy for breast and prostate cancer.
Yes, they apply these highly concentrated PN creams to prevent severe skin toxicity and mucositis in real time.
Exactly. So it leaves you wondering, if they can use topical PNs during treatment because there's no needle and therefore no infection risk, could the future of oncology care involve entirely needle-free topical polynucleotide therapies applied directly to the pelvic mucosa during chemotherapy?
It's a fascinating question. If a topical delivery system can penetrate the submucosa deeply enough, you could potentially maintain the microvascular network and collagen structure throughout the nadir.
You could protect the tissues in real time, preventing the damage from ever getting that severe without ever risking an infection. It completely shifts the paradigm from post-treatment salvage to real-time preservation.
The cellular science of the polynucleotides already supports it. It's really just a question of evolving the delivery mechanism.
It is definitely something for you to ponder long after this deep dive ends.